Hi. Good morning, everybody. Afternoon. We will be talking today about molds, since we kind of see them relatively often at Moffitt. So I just wanted to give you a brief overview of the terminology that you can hear once in a while when you're covering Moffitt. Remember that yeast are unicellular fungi that reproduce asexually by blastoconidia formation or budding. The screen doesn't work. Hyphae are multicellular fungi. So every time you see hyphae, then you have to think in mold. Okay? The morphisms are yeast. There are these organisms that can reproduce as a yeast or as a mold. So, we're here podcasting, Dr. Nash. So, so this is part of the terminology. Again, when you, these are the hyphae here at the bottom, and these are how the upper part are yeast. So hyphae can look like this at the bottom, and you can have septated or aseptated hyphae, and that will give you the big groups of mold: septated or aseptated mold. Okay, so every time you hear pseudohyphae, think about yeast. Every time you hear hyphae, think about mold. Every time you hear mycelium, that is also consistent with mold. Okay, that is a mass of hyphal elements. Conidia or spora, that means asexual reproduction. Macroconidia is a large complex of conidia. Microconidia, small conidias, and those sporas are conidias that are inside of a sac. So, when you have a septated hyphae, it could be anywhere from Aspergillus, Fusarium, or Penicillium. But you won't know until you see the shape of the conidias. See, for example, right there in the upper part, you see the conidia of Fusarium. It looks like a flower, but we don't have that one in here. But Fusarium, for example, the conidias look like banana shape. So many times in the micro, they want to have the mold to grow, so they can see all the morphology of the mold to tell you, yes, this is Penicillium, this is Aspergillus, this is Fusarium. On the smear, you may only see hyphae. See that's that one over here. This is Rhizospus, that belongs to Zygomycosis. See, it's round conidias there. And the hyphae over here, they are aseptated. So thinking more like you would think in a kind of like a tree. So when they call you and they tell you that the hyphae is septated in 45 degrees, you immediately think in Aspergillus, because that's the most common mold. And in general, the septated molds are treated with voriconazole, with very, very few exceptions. They may not be completely susceptible to voriconazole, and then it's a little bit tricky, but in general, you can use voriconazole for all of these. But the aseptated mold, that includes Zygomycosis, and then you have to use what? Amphotericin. This is another slide that tells you how they could be aseptated or septated, depending on the species that they belong to. So let's go with a case. 56-year-old male with history of AML who had a mismatch unrelated allo stem cell transplant. Today is day number 30 after the transplant. She had GVHD of the skin and the GI tract, and she's she's admitted because of shortness of breath and fever. You do you do a CT scan of the sinuses, CT of the chest, and you see all these tiny nodules there. You look at her skin, and this is how it looks. And you take a biopsy, and you look at the smear, and that's what you see. What do you think she has? Fusarium. So, Fusarium can cause a systemic infection by infection of the line or a toenail, that if the patient has a trauma and is immunosuppressed, the Fusarium that colonizes the toe can go inside and cause infection. That infection could be metastatic, and the spores can travel through to the lung and even brain. So you can see here the cornidias that look like a banana shape, and the hyphae is harder to see, but they're septated. And then the skin lesions, they start like a erythematous nodules that grow and develop a necrotic center, and they are very tender. Fusarium is usually found in the soil, water, in the nature in general. Fusarium solani, Oxiosporum, and moliniforme are the most common species. And it is interesting that up to 17% of the people that are healthy may be colonized with Fusarium in the throat. So you can argue, if these people get immunosuppressed, can they get sinusitis with Fusarium? And then with postnasal drip, can they get Fusarium pneumonia? So that could be another way to get Fusarium. And there have been outbreaks of the contact lens due to Fusarium. The most common mold found in immunosuppressed patients, of course, is Aspergillus. That's why when you get a call to tell you that the patient has Aseptate hyphae, you immediately think in Aspergillus. But Fusarium is the second most common mold, and it can also have Septate hyphae. It is angioinvasive, meaning that travels to the blood from the blood vessels. And one thing important to remember is that if somebody has Fusarium infection or Aspergillus, and the patient receives chemotherapy, complete treatment for such infection, and comes back for another chemo, you have to give prophylaxis against that mold for as long as the patient is neutropenic, even though the patient already completed treatment. Why? Because the spores hide in the blood vessels, waiting for the opportunity to grow and proliferate. It's not rare for us to see patients at Moffitt who had nodular pneumonia presumptive of mold infection on a CAT scan, and that they were treated, the pneumonia resolved, and a year later they come back, and let's say they didn't get the mold prophylaxis for whatever reason, they will develop the same nodular pneumonia in the same location in similar shapes. So it's very interesting. The skin lesions that you can see in Fusarium are called bull's eye. Just because you see the picture there with the eye, they may look a little bit like that. Again, the nodules could be pruritic, so very painful. The risk factors include prolonged neutropenia and related stem cell transplant, patients who have GVHD and are profoundly immunosuppressed. And it can also cause isolated sinusitis and even isolated pneumonia. That's less common, but it can be seen. Also, you see when you do a CAT scan, these nodules due to Fusarium are multiple and very small, as opposed to the nodules caused by Zygomycosis. So sometimes when I was a fellow, I was confused because some people will say you treat Fusarium with amphotericin. Some people will say, no, you treat it with voriconazole. So I started looking and I found data, and there are papers out there, and basically you have to remember that Fusarium solani and verticilloides are resistant to azoles, and amphotericin is recommended. Fusarium moniliform species are resistant to amphotericin, then voriconazole or posaconazole is recommended. So which one you use? Unless they give you the specific of the species, you won't know. And it's a sent out test. Most of the hospitals don't do it. And because we see these infections in profoundly immunosuppressed patients, patients who can, usually what we see at Moffitt are patients who have a trauma in the toenail. And the toenail becomes dark, necrotic, and then from there they develop nodular pneumonia. And we had a patient who ended up having transmetatarsal amputation and had Fusarium endophthalmitis, and he lost the eye. And the Fusarium was isolated in both the toenail and the eye, but the patient is alive. And we had to use, with him, we had to use amphotericin and voriconazole just because we didn't know the subspecies. So that's why we've been using amphotericin and voriconazole, because we don't know what, if it's Fusarium solani or Fusarium moniliform. Again, the conidia shapes. Going back to combination therapy, there are different papers. Basically, we have in vitro data, studies in animal models, but nothing, no prospective studies in humans evaluating the combination therapy for Fusarium versus single therapy. But there is a potential benefit, but it could be because we don't know which species we're dealing with. So let's continue with the case. The symptoms of this patient resolve, and a year later, he comes with sinusitis, pneumonia, and mental status changes. He remained on voriconazole as you prescribe because he had Fusarium. And then you do an MRI of the brain, and you see this. So, and you do blood cultures, and they're positive for mold. What's your differential diagnosis? He had Fusarium, and he's been on voriconazole. Now he has a brain lesion, and you do a blood culture, and he has a mold. Which is the mold that behave a little bit like Fusarium and may not be covered by voriconazole? It's a good thought, because Aspergillus terreus is very tricky, resistant to amphotericin, and the susceptibilities to azoles may vary, so possibility. Scedosporium what? So there are two big species of Scedosporium, proliferans and what's the other one? Don't remember. But, Pseudoascleria bollei is the other name of the Scedosporium. So, but the worst Scedosporium to have is Scedosporium proliferans. And just remember, proliferans, it proliferates. So, Scedosporium and Fusarium behave very similar. So if they ask you a question and to tell you that a patient has a mold in the blood, there are two big possibilities, Scedosporium or Fusarium. They are all love to cause distant infections, sending sporas from, even it can go to the brain, it can go to the lung, etc. So Scedosporium angiospermum is the one that Georgina was mentioning, Pseudoascleria bollei. This is the good guy, the one that may respond to voriconazole. But Scedosporium proliferans doesn't respond to voriconazole, and really there is no good treatment for that. And most of the patients have a bad prognosis when they have it. And the way to remember, at least that helps me, is proliferans. It proliferates no matter what you do. So that one is resistant to voriconazole. Again, we already talked about the dissemination. You can get it by inhalation or cutaneous inoculation. Scedosporium, just like Fusarium, is angioinvasive. Again, more commonly you have blood cultures positive with Scedosporium proliferans than with angiospermum. Now, if you see Scedosporium in a sputum or in an airway, it is not a colonization. It is an infection, and you have to be concerned about that. But you're not going to find it in a healthy patient, as opposed to Fusarium that can be found colonizing the throat in healthy patients. Scedosporium really, it's a mold that breaks through when the patient has been heavily treated with antifungals. Voriconazole is the drug of choice for Scedosporium angiospermum, and echinocandins may have some activity. Some reports out there that using terbinafine and azole and amphotericin or pentamidine may be used too. These are desperate measures when the patients are dying from refractory leukemia and prolonged neutropenia. Other septated molds, of course, we knew about Aspergillus, so we already talked about Fusarium also, Scedosporium, and also Pycilomyces and Trichoderma can be septated molds. Let's do another case. 50-year-old female who had an allo stem cell transplant 2 years prior to presentation. She has a GVHD of the GI tract and the skin. She complains of fatigue, shortness of breath, and cough. Her medications include prednisone, tacrolimus, Celcept, molybdenum for PCP prophylaxis, and acyclovir for HSV and VCV prophylaxis, and also voriconazole. Her physical examination is remarkable for tachypnea and fever. She has disseminated breath sounds at the bases. You do a CAT scan and you see this. We saw a case like that, Kevin. You remember? What is this? Zygomycosis. What's the sign? Reverse halo sign. So remember, halo sign is a dense area surrounded by ground glass, and reverse halo sign is just the opposite. It's just a dense area that surrounds a ground glass. This was first described in an article in Clinical of Infectious Diseases, case series from MD Anderson, transplanted patients who had these findings. And one of the interesting things was that most of the patients were on voriconazole. So they were saying if voriconazole was a risk factor. Probably not, but voriconazole doesn't have activity for zygomycosis. So if the patient is profoundly immunosuppressed, eventually something is going to break through. We already discussed this. Reverse halo sign can also be seen in pulmonary infarctions and Wegener's disease. So let's say that you change voriconazole to posaconazole and amphotericin was added. The next day the patient felt much better, and again, the biopsy reveals zygomycosis. Unfortunately, you cannot always do a biopsy on these patients because they have thrombocytopenias. You can have high morbidity and mortality associated with these procedures, so you have to kind of train your eyes and think what is breaking through, what the CT findings are more likely consistent with, and go from there. Again, these bring us to the aseptated molds, which include Zygomycosis species. They can be found again in the nature, in the soil. The most common species is Rhizospus, but of course mucor can be there, Cunigamela and Absidia corymbifera. Why is important for the ID fellows to remember these species? Because sometimes they may tell you, oh, we have Rhizospus, we isolated Rhizospus on these patients, so you need to know what to treat with. What are other risk factors? We have diabetes, iron overload, trauma, burns, neutropenia, steroids, previous use of voriconazole, and because I just told you, this reverse halo sign was described on transplanted patients who were on voriconazole and developed GVHD, and then when they were on steroids, tacrolimus, Celcept, they were profoundly immunosuppressed. We already discussed the series where this was found. You can have rhino-orbital cerebral or cerebral infections due to zygomyces. You can have pulmonary zygomyces. You can have GI zygomyces. And we had a case at Moffitt, a patient who had prolonged neutropenia, healthy 30-year-old, who presented with right lower abdominal pain. So we say, okay, this is typhlitis or neutropenic colitis. Let's go ahead and treat. He was on voriconazole, Zosine, I believe, and of course acyclovir for prophylaxis. He continued to do not too well, ended up requiring surgery, and his cultures grew zygomyces. Interesting. So you can have it in the GI causing infection. And why? I don't, patients eat different things. Who knows what he was eating? Why he was colonized with that. You can have renal zygomyces. You can have cutaneous inoculation of zygomyces after a trauma, particularly if you are immunosuppressed. And the skin lesions can look just like that. And this patient had cutaneous zygomyces. And if you take a look at the skin, this was a patient who was neutropenic. And it's almost as if you were looking at a culture and you were seeing like a cotton colonies of a mold. See, there is this dense necrotic area, and there is this inflammation around it, probably meaning that the mold was causing angioinvasion deep inside, just like it does in the lungs. So interesting. Some more examples of zygomyces infection in diabetic patients. What's the diagnosis? You have to do endoscopic evaluation for pulmonary zygomyces, basically your CT chest and how the lesions look. If the patient has reverse halo sign or a big, large nodule, and this could be associated with pleural effusions. You can always try to do a bronchoscopy with lavage, but the success of this is not very good, and you ended up having to treat empirically based on what you think the patient has. Lung biopsy if you can, but not always is possible. You see these are aseptated 90 degrees hyphae seen on zygomyces. And there are some conidias there that are round, somewhere around the smear. The treatment of choice is amphotericin. Posaconazole has also activity. It's recommended for patients who cannot tolerate amphotericin. But unfortunately, many times the patients that we see are too sick to be able to eat a fatty food in order for the posaconazole to be absorbed. Echinocandins, there are some papers out there that says that Rhizospus has the for Rhizospus, echinocandins may have some activity. So these are some papers out there on combination therapy for zygomyces. This is oh no, I'm sorry, this is not combination therapy, but this is the paper about posaconazole being used for zygomyces. We already discussed this. In vitro data saying that that echinocandins may have some activity and may be used in combination therapy. Again, no prospective data. And Rhizospus may have the enzyme that's target for echinocandins. More data in combination therapy. Posaconazole combined with amphotericin in murine samples. So the conclusion is, according to that paper, was that the combination of posa with amphotericin amphotericin was not superior to high doses of ampho alone, but at least the combination did allow the reduction of the dose of amphotericin with no loss of efficacy. More papers, poly-N and caspofungin for zygomycosis. Again,